Hi, my name is Shani Quevedo, and I'm an internal medicine resident at Aventura Hospital and Medical Center. I present this case to you today, but now without the help of Dr. Khan, Dr. Rolon Rosario, Dr. Yoel Tajes, Dr. Medina Perez, and our attending Dr. O'Brien. We do not have any conflicts of interest. The title of our case is CMV Encephalitis as the first presentation of AIDS. Cytomegalovirus, or CMV, is a double-stranded DNA virus known for causing disseminated or localized disease in HIV-infected patients who are immunosuppressed. While it is rare in immunocompetent individuals, a prior study showed that out of 676 patients presenting with CMV encephalitis, 85% of them had AIDS. However, it is most common in these patients when CD4 count is less than 50 and there are high circulating levels of HIV RNA present. We present a case of CMV encephalitis as the initial presentation of HIV in a patient with a CD4 count that was greater than 50. Our patient is a 65-year-old Haitian male with no known significant past medical history who presented to the emergency room with altered mental status and word-finding difficulty for about 2 weeks. Physical exam revealed a cachectic male with an ataxic gait who became incontinent upon standing. His initial blood work was unrevealing, and brain CT was notable for mildly dilated ventricular systems. A subsequent brain MRI did not reveal hydrocephalus or ventricular effacement, but it did show ventricular megaly and scattered white matter-enhancing regions. EEG and syphilis studies were negative. However, the rapid HIV test was positive, and the initial CD4 count was 65. He was later started on prophylactic treatment with Bactrim. Over the course of the hospital admission, his mental status became increasingly altered. A lumbar puncture was performed, and it revealed a sterile and a cellular CSF. The encephalitis panel workup was positive for CMV with an initial viral load of greater than 55,000. As a result, he was started on treatment with IV ganciclovir. However, throughout admission, despite continued therapy for the infection, he remained encephalopathic with minimal improvement in his mental status. He was to continue treatment with oral ganciclovir once transitioned for a minimum of 6 weeks. And he was later started on heart therapy and advised to maintain outpatient follow-up. CMV encephalitis is a rare disease that will most likely present in immunosuppressed patients and rarely in immunocompetent individuals. The occurrence of CMV disease in patients infected with HIV is closely related to the CD4 count. It is typically seen when the HIV viral load is greater than 100,000 and CD4 count is low. CMV viremia is predictive of death, and it provides a prognostic factor, with higher CMV viral loads correlating with clinical symptoms. Patients with CMV encephalitis present with altered mental status that can easily mimic many pathologies. However, confusion, delirium, and focal neurologic findings in the setting of immunosuppression are associated with CMV encephalitis. On imaging, nonspecific increased T2 flare signaling in the white matter is usually the only finding seen on MRI. The treatment of choice is ganciclovir or ganciclovir and foscarnet. In the case of our patient, he was reportedly a previously healthy, completely independent male without any known past medical history who presented with symptoms similar to that of normal pressure hydrocephalus and later found to have CMV encephalitis despite having a CD4 greater than 50. This case emphasizes the importance of keeping a broad differential when encountering symptoms of encephalopathy, especially in patients who have an initial negative workup in the setting of acute neurological symptoms.